and consultant at JSS Medical College and Hospital. He's done his MD from KMC Bangalore. He has a fellowship in cardiac anesthesia from Narayana Hrudayalaya, Bangalore. He has 8 publications and 2 international publications in his account. His special interests are post-operative analgesia and anticoagulation in cardiac surgery. Now I call upon the next chairperson, Dr. Sridevi ma'am, to come on the dais. She is the Associate Professor from Chamarajanagar Institute of Medical College, Chamarajanagar. She has done her MD Anesthesiology from KMC Chennai. Her field of interest are difficult airway, management of critically ill patients, and regional anesthesia and obstetric anesthesia. Now I would like to call upon Dr. Vasudeva Upadhya, sir, to deliver his CME talk on pulmonary function test. Over to you, sir.
Good afternoon, everybody. I welcome you all to this South Zone Conference and ISA Karnataka State Conference. I'm sure after a sumptuous lunch, we'll have a great academic session regarding the pulmonary function tests, how to manage a COPD patient in non-pulmonary posted for non-pulmonary case, and management of patients posted for minimally invasive thoracic surgeries. I welcome the first speaker, Dr. Vasudeva Upadhya, sir, who is the professor at Department of Anesthesia, Pain Management and Critical Care at Muddenahalli Medical College. Welcome, sir. Sir has got a teaching experience of 29 years. His special interests are in pediatric and transplant anesthesia, pain and palliative care, complementary medicine, regional blocks, difficult airway management. Sir is a life member of ISA and IAPC. We are just speaking, and sir was saying about his vast experiences in managing pediatric cases with congenital heart diseases. I'm sure sir is a treasure trove of knowledge, and without much wasting time, we'll go ahead with the talk. Welcome, sir.
Good afternoon. It's a post-lunch session, and our passion is to make people sleep. So post-lunch, lunch is like pre-medication, and if you all sleep, I am good at my work. That is my conclusion. So I thank the organizers for giving this excellent opportunity, and welcome you all for the post-lunch session. Pulmonary function test. It's a very, very vast terminology if you ask me. And unlike cardiac function tests where there are some specific things like ECG and all that, here they are not, there are so many things which can vary the results depending on age, gender and things like that. So there are some objective data. If we take all that into consideration, we can make it more objective. But the key is to know the history and physical examination, and we need to use the patterns in the results. So then only we can make it more practical. The principal function of lung is gas exchange. So there is respiration, there is lung parenchymal tissue, and there are cardiopulmonary interactions. So if we can test these things, we can call it as pulmonary function test. So the normal ventilation, the first part depends on the intact neuromuscular, unrestricted movement of chest wall and the air passages, lungs, and there are lung volumes, ventilation capacities and mechanisms of breathing. These things we must evaluate when we check the pulmonary functions. So what are the goals? It is to predict and to quantitatively have the baseline and identify the patients who are likely to have benefit from bronchodilators, and if there are some special situations like cardiac and pneumonectomy, how we can do it. Then what are the indications? Indications are quite wide if we want to. Now their indications are increasing as more PFT labs are available, more sophisticated investigations become indicated if we look at it from that point. Otherwise, there are some simple tests which can help us. That is to quantitatively evaluate the respiration in specific patient groups. Early detection, this is very important. Almost 7-8 years before they manifest in the other things, we can see that whether they are affected or not, COPD, etc., when they smoke. So we can use it for preventive medicine also. And in elderly patients and all, we can get it done. Certain drug toxicities. I am saying this as anesthetist because our scope is expanded now and we are critical care specialists and emergency medicine, everywhere we are there. We are actually perioperative physicians, so we must know about it. And also to fitness for high altitude, etc., pulmonary function test can be of some use. Contraindications, recent eye surgery, thoracic abdominal aneurysms, active hemoptysis, pneumothorax, angina, etc. They are common for many such things. The most important thing is bedside tests. Is it relevant in the present context where we have got so much of sophistications, so many equipments? It is still relevant because we are providing anesthesia even in remote places now, where we may not there may not be so much of commercialization or possibility of having all sophisticated pulmonary labs. There what comes handy is, I am the physician, I am everything there in many places. I come from a small village, even my medical college is in a village. Of course, in our hospital we have a lot of facilities, but most of the places I have seen that we don't have access to many facilities and we cannot cancel or refer them to go to cities and get these things done. The most simplest test, the bedside pulmonary function test, if you ask me, is the respiratory rate, especially in pediatrics. If the respiratory rate is high and if you have taken care of anxiety, it is a very good indication. I think during COVID time, even common people have come to know about it. Then there are some tests which are important both from examination point of view for students. That is because the examiners know its practical importance. It is not that they are, one warehouse of history and they ask. They know the practical implications and that's why they ask. So some of the simple tests are there. That Sabre's breath holding test. It is an indication of vital capacity and cardiopulmonary reserve. So the normal values and all, I will not go into details. I have made these slides with little extra information, keeping in mind nowadays many a times they don't give write-ups or something. They upload it in the YouTube or something like that. So if the students want to use it, it should give, what I say here may not be available, but the slides may be uploaded and available. So I have put little overcrowded slides. I am sorry about it, but I am sure it will be useful for not just this many people. Maybe it will benefit some more people. Then Snyder's match blowing test, it tests the maximum breathing capacity. It is, if it is more than 60 liters per minute, it indicates, the normal blowing indicates it is more than 60 liters per minute and FEV1 is 1.6 or more. There are modified tests, again I will not go into details. The cough test, patient is asked to cough and then it indicates what is the forced vital capacity and the FEV1, what is the value, and it gives. Then forced expiratory time, that also tells us about we auscultate over the trachea and see whether there are any bronchi and how much time is taken. If the time taken is long, it indicates that it's a restrictive lung disease. Patient breathes, takes 5-6 breaths, and if you auscultate between the scapula and if he is wheeze, then the wheeze test will say it is positive, indicates obstruction. Single breath count, it indicates the vital capacity, and we keep 1, 2, 3, 4 like that, how many numbers can count. So if I want to know, especially during COVID and all, so many people had, they wanted to know, if they are able to count, they can be sure that they have enough respiratory reserve. So if they count up to 30 to 40, it indicates their capacity is normally, it is acceptable or it is normal. Then right flow, peak flow meter, it's a simple instrument which can be used. It indicates the efficiency to cough effectively. De Bono's whistle is something like a flute that will have different holes, and you keep closing it and it will indicate how much is the, you can read it, the readings are there on the tube itself. As you move you unthread the tube, the holes get closed, and if how much you can, the sound is not there, then you can calculate. It's a simple device. And as I said, first the respiratory rate, finally, not the least, is the pulse oximeter. They are available everywhere now, even at home, even at bedside. That is another most important bedside instrument which can tell us about the pulmonary functions. These are the bedside tests. Now, when we talk about spirometry and lung function tests, it is the static volumes. I am sure all of you are aware of these volumes, so I am not going to read out the normal values. The spirometry, there are different ways of recording it. This is the normal spirometry we have been reading from physiology days onwards. So it has not changed. Again, I will not go into details of this. So what are the things we can measure in that? I have already shown it. The functional residual capacity and the residual volume we cannot measure by normal spirometry. So we have to use different techniques like nitrogen washout, helium dilution, or body plethysmography. Another important parameter that we want to know as anesthetist is the closing capacity and closing volume. It is very important for pre-oxygenation, inhalational agent, and post-operative complications. If the closing volume is more, or if it exceeds the residual closing capacity, then the volume is more, then it indicates that the more alveoli are not available for gas exchange. They use nitrogen, single breath nitrogen breathing out technique. Then comes, all the static, then comes the dynamic volumes to determine the maximum air that can be breathed in or out and how fast we can do it, in simple words. So the common indices that are read are forced vital capacity and the volume that can be exhaled forcefully and fast within the first second, and their ratio, and the mid expiratory flow rate, that is between FEF between 25 to 75%. Normally nowadays we get it automatically in the computerized spirometry thing, so I will not go too much into detail. So hope it is visible. Again, lung volumes and capacities. This is a spirogram. Again, it is not routinely used, just to know what are the volumes and what are the capacities and how FEC, FEV1, FEC ratio is calculated. That is different. We cannot measure, as I already said, the residual volume and the functional residual capacity. These are flow volume loops. These are most commonly used in depicting pulmonary function tests. They measure the forced vital capacity. You can see here the typical normal and with the obstructed disease, restrictive disease, extrathoracic or fixed airflow obstruction. Little bit of detail about it. What is the normal curve? The expiratory portion, if you see the B in the picture, if you see, it is called a scooped out thing in the expiratory limb. So that is very typical of expiratory obstruction. Then restrictive, the volume is very narrowed. You can see it very obviously. The magenta colored one is the abnormal depiction. So it is superimposed. You can see it very nicely how it is seen. Next is extrathoracic. You can see the inspiratory limb is collapsed there, the flow. And if there is a fixed obstruction, both are collapsed as seen in the last graph. Then I am sure you can't see it much, so I have tried to explain this. This is just to give you a flow how we assess stepwise manner. So there are few things. If you see in the here, the first is to see acceptability, whether it is reproducible, and reference value with predictability. So confirm the patient demographic data. This is extremely important because they may bring so many results and they will keep it on your table, and same names may be there, and sometimes they may enter, number may not be entered properly. So we have to make sure that the patient and the report, they are tallying and it belongs to the patient. So values vary, as I said in the beginning, depending on so many factors. What is important is the predicted value for that patient. In other words, it is individualized. They are calculated using computers and regression equations. Normally, the computer gives you the value, predicted value, and also gives you how much is the percentage, and that is what we take. Acceptable criteria, when the PFT is done, there are few things which need to be taken into consideration. I have enumerated them, that it needs lot of patient's cooperation. One important thing, apart from the demographic criteria, if the patient is not cooperative or not able to do it for pain or some such reason, the readings will go haywire and it will not give you much value about its usefulness. Then interpretation, next step is interpretation. You have to see FE1, FEC ratio. It will tell you about the obstructive pattern or it is restrictive. Then you can classify COPD depending on your PFT test, and you have to do it after bronchodilation, and what is the normal accepted to say that it is reversible or not, you can use it. It is classified as mild, moderate, severe and very severe. Very severe if there is a right heart failure, even if there is a slightly better pulmonary function, we take it as very severe only. Total lung capacity, again it is to depict the restrictive disease. Again it is classified as depending on the predicted value, mild, moderate, severe and very severe. Then how do we assess the perfusion? Perfusion is assessed by carbon monoxide. Yes, it's very small amount of carbon monoxide. It is not to cause any carbon monoxide poisoning. A small dose of carbon monoxide is inhaled and then we can measure it and we can see whether it is obstructive or restrictive and how is the perfusion happening. Then how do we differentiate restrictive, obstructive and combined depending on these volumes and also the perfusion. Again, I will not go into details of this, it is available in your literature. What is important is we can use these things to differentiate the pulmonary functions, can be used to differentiate restrictive, obstructive and combined disorders. Then forced mid-expiratory flow rate, that as I said 25 to 75% of the normal value is expressed as predicted and it will show the level of obstruction. It is taken from the expiratory flow diagram from 25% to 75%, how much is there, and that is depicted. Peak expiratory flow rate, that is one quick exhalation and ventilation adequacy and airflow obstruction is evaluated. Again it depends on so many factors, and the importance of this is whether the patient is able to cough effectively or not. Maximum voluntary ventilation, that is how much I can breathe in a minute. Normally it is not done for 1 minute, maybe 12 to 15 seconds and it is multiplied and it gives us the reserve, how much reserve we have, how much more we can breathe for the increased need. So it is compared again for resting ventilation with the ventilation required for a given exercise, and it can be used to see the degree of dyspnea, and we have something called dyspnea index which will again give us about the total reserve we have. Then next is, as I said, gas exchange. Gas exchange depends on the ventilation, volume distribution and how the diffusion is happening. Then about the volume, as you all know, it is the dead space, anatomical, physiological dead space is there, alveolar dead space is there. So we need to see how much is wasted in the ventilation and how much obstruction or pulmonary restrictive disease is there. Multiple factors are there in the alveolar distribution, whether it is evenly distributed or not, if there is something like kyphoscoliosis or something like that which can cause, or if there is obstruction that can cause maldistribution. Normally nitrogen washout is used again to evaluate. Next is about the diffusion, transfer of gases across the alveolar and capillary membrane. Again, as I said, carbon monoxide is used here and normal values, how much is the normal, we can use it to evaluate. It depends on surface area and the blood, how much it can take. Both are important in diffusion. Diffusing capacity using carbon monoxide, where it is used, you can see both cardiac conditions and things like anemia also can affect the diffusion because it has to absorb also. I am just putting it to say that multiple factors are involved in diffusion also. So diffusion is increased, as I already said. Anemia is an example, emphysema is another example. Pulmonary fibrosis is where there is parenchymal involvement. The basic aspects are gas exchange or ventilation, perfusion, alveolar gradient, and what is happening to the circulation, that is shunt. Again, these equations I am sure you are all familiar, I am not going into it. So anatomic shunting, functional shunting, and diffusion defect happens, and alveolar oxygen tension is and arterial blood gas tension are required for measuring these parameters. Again, depending on hypoxemia, we can see, I don't know how much whether you can see clearly. Again, because of the restricted time, I don't want to go into details because that itself will take 20 minutes. So I am going little faster here. Test for cardiopulmonary reserve is a different topic, so I am not going to elaborate on that because cardiac and pulmonary, they work hand in hand. So those tests are very important because we cannot separate them like 6 minutes, stair climbing tests. So there are so many number of tests. We must keep them in mind, and we must know that they always interact, and it is not always possible to differentiate those two. So again, this is about the same thing. So this I will not go to it. So this is important. These are which test to do when and what to. So I will take maybe just 2 minutes to finish this because this gives you the whole summary of the what I spoke, which test to do when and what to detect. Dyspnea at rest, if the patient has got, what you can do is spirometry, lung volumes, DLCO, ambulatory oximetry on stair climbing, advanced cardiopulmonary exercises. Cough and asthma is there, you can do spirometry after bronchodilator and bronchoprovocative tests in selected cases. COPD, you are all familiar, so I will not go into too much of details of that. Suspected bronchiectasis, again spirometry before and after bronchodilator and lung volumes. If it is bronchiolitis, along with that you can do carbon monoxide diffusion also. If it is upper airway obstruction, I am not saying about bronchoscopy and all. What pulmonary function tests we can do is spirometry, and if it is interstitial lung disease, spirometry, lung volume, carbon monoxide, and oximetry at rest. Neuromuscular, again you can evaluate using spirometry, lung volume, maximum inspiratory force and expiratory force. And suspected diaphragmatic weakness, you can again repeat this spirometry or lung volume, maximum inspiratory and expiratory force. ABG of course will give you much more better thing. Thank you very much. Thank you for patient hearing.